Good evening, everyone. Thank you for tuning into our first webinar of 2019. My name is Ashley Duyan. I currently serve as the Education and Base Building Team Leader for Students for National Health Program. This semester, SNAPS will be hosting an interprofessionalism webinar series looking at how Medicare for All will impact the fields of dentistry, nursing, physician assistant, public health, and PhD in medical research. Our organization is made up of health professional students of all fields, and as such, we would like to talk about how Medicare for All would impact our future patients in all aspects of their health care. For those of you who are dental students watching this, you may be wondering what is Students for a National Health Program, or SNAP, as we call ourselves, and why should I get involved? Students for National Health Program is the student arm of Physicians for National Health Program, or PNHP. PNHP is a single-issue organization advocating PNHP is a single-issue organization advocating for a universal, comprehensive, single-payer national health program with more than 19,000 members. We believe that a single publicly funded, privately delivered universal healthcare system is necessary for us to provide high-quality care to all of our patients. Despite spending more than twice as much as the rest of the industrialized nations, the United States performs poorly in comparison on major health indicators such as life expectancy, infant mortality, and immunizations. Moreover, the U.S. leaves 33 million people completely uninsured and millions more inadequately covered. Single-payer financing would save, on paper, more than $400 billion per year, which would be enough to provide comprehensive coverage to everyone without paying any more than we already do. While the Affordable Care Act expanded Medicaid and mandated the purchase of private insurance, it still left nearly 25 million people uninsured. Today, that number is greater than 28 million and climbing. The ACA had no concrete way to curb skyrocketing healthcare and administrative costs associated with a for-profit private healthcare industry. It's for that reason we can see a single-payer system in our lifetime, and we believe the time to act is now. Our presenter this evening is Ben Wang. Ben Wang is a fourth-year Doctor of Dental Surgery candidate at Columbia University College of Dental Medicine and a member of the Columbia University Medical Center SNAP chapter. As a dental student, Ben has been actively involved in addressing oral health disparities on a variety of fronts, including managing a free dental clinic, conducting research in preventative dentistry, and through advocacy in organized dentistry and SNAP. He received his BS in anthropology from Duke University in 2015 and will be continuing on to a comprehensive dentistry residency program in the United States Air Force upon graduation from dental school. There will be an opportunity at the end of the presentation for questions and commentary from the viewers, either via the microphone or chat function. It would be appreciated if everyone watching could mute their microphones until that point. If you have questions for Ben during the presentation, please type them into the chat bar on your GoToMeeting control panel, and I will be moderating throughout. So without further ado, I'll go ahead and give it to Ben Wang with defining Medicare for All, provisions for oral health care.
Okay, thank you, Ashley. Hopefully everyone can hear me pretty well. My presentation is called Defining Medicare for All, Provisions for Oral Health Care, and we'll get into it. So I just want to start off with an overview of, what oral health is and what is the status of oral health in America. I understand that, some might be dental students listening in, some people might be medical students, other health professions, and I just wanted to give everyone sort of a ground foundation about what oral health is, and who treats it, and how it is financed and delivered in our country. So oral diseases and disorders are very important to health and well-being throughout life, and it doesn't just refer to teeth. Oral health includes conditions affecting the oral facial, craniofacial complex, oral and pharyngeal cancer, oral soft tissue lesions, birth defects such as cleft lip and palate, and other diseases and disorders that can affect the oral facial complex. Two of the most common chronic diseases in the United States, dental caries and periodontal disease, are included in oral health. So dental caries is actually the most common chronic disease in U.S. children. This is something that's not known by a lot of practicing physicians. It's actually 5 times as common as asthma and 7 times as common as hay fever. The other big oral health disease is periodontal disease, which is colloquially known as gum disease. And over 50% of Americans have some form of periodontal disease, including gingivitis, which is inflammation of the gums. Um, there are what is important also is that dental caries and periodontal, two major diseases of the oral cavity, are actually are very much preventable. Water fluoridation, as a lot of us are familiar with, is regarded as one of the most successful public health measures and has led to a lot of cost savings in terms of cost savings on treating dental decay. Oral and craniofacial health is also very important to overall well-being, and it's greatly influenced by lifestyle factors that affect your general health, such as tobacco use, excessive alcohol use, and dietary choices. So all in all, the mouth is a reflection of one's general health and well-being. What is also striking about oral health in America is that, as it was dubbed in the 2000 Surgeon General's report on oral health in America, is that there's a silent epidemic in our country, and that there are profound and consequential oral health disparities. Dental diseases are often the highest among the poor, people living in inner cities, in rural areas, among ethnic minorities, and often in populations that also have the most difficulty in accessing healthcare to begin with. There are also striking disparities among education lines, poverty level, and also age disparity as well. Poor children and the elderly are particularly prone to oral disease. At least, yeah, there's some other statistics that are, representative of how we have oral health disparities, but I just want to go on. And now I'm going to get into how oral health is actually connected to your mouth and your body. So I think that this is something that we learn a lot about in dental school, but understand that other health providers might not always have the most oral health content in their curricula. I think it's something important to stress, given that a lot of what I'm going to be talking about has a lot of ramifications outside of oral health as well. So oral health is intertwined with the variety of systemic illnesses as detailed in this infographic. Heart disease, diabetes is very big, especially there are striking connections between diabetes and periodontal disease. And overall, there's a lot more, again, to oral health than just teeth. And now going into the history of dentistry, I think this is also important because it sort of gives us an insight into why dental insurance and medical insurance are separate. If you look into how the professions were laid out in the United States and also in other countries, it gives you sort of an idea as to how we got to where we are today. So the history of dentistry, if you can see in this sort of picture here, you can see this is a very ancient dentist. They've had their roots in a profession called a barber surgeon. They were someone that cut someone's hair, but they also performed some other tasks for their clients that came in to visit them, such as extracting teeth to alleviate pain, chronic tooth infection, and they also did perform some other procedures such as bloodletting and cupping. And I think this is particularly important because this is the root of dentistry, and sort of how this profession evolved into gradually becoming more and more of a scientific profession. So in the early years of the United States, dentistry was an unregulated trade, but gradually the medical establishment helped to transform dentistry from a trade to a profession, and they brought scientific rigor to the practice of dentistry. The first dental school was formed in 1840 in Baltimore, and it was a lot of early dental schools definitely benefited from physician leadership and as well as financial and structural support from medical school faculty. So today what we have is this is sort of a picture, a map of dental schools around the United States and Canada. So all of these dental schools that were started in around the mid-1800s, today we now have 66 in the United States, and there are also a couple in Canada. And what do they do? The majority of these dental graduates will go on to work in private practice, but there are also dentists who will work in a variety of other settings, in government, in hospitals, in public health centers. And what's also another minor trend is that more and more dentists are actually working in group practices. It was very common for dentists back in the day to work in practices of 3 dentists or less in private practice, but more and more practices are sort of being consolidated, is the term they would call it, and dentistry is sort of following trends in healthcare. So modern practice of dentistry. Dentistry is actually the last cottage industry of healthcare. It's composed of mostly small firms and a few large firms, in that, you know, it's mostly private practice, and there are a few larger entities, but mostly small entities. 88% of dental offices in the U.S., as I mentioned, have 3 or fewer dentists. What this means is that I think a huge implication is that dentistry is very siloed from the rest of the healthcare system at large. You know, whether you have private practices that only operate with a few dentists, or even private practice, the significance of private practice in general, sort of connections between dental care and overall medical care are very separated. And this sort of goes along with lines of what I've been harping before, sort of the origin of the profession was separate, and this also manifests itself in the practice of dentistry itself. Okay, and now going into how insurance evolved. So this, again, will follow the same sort of trend as dentistry evolving as a separate entity apart from medical, from medicine. Okay, so the origins of insurance. So medical insurance first started with a collective of techs and school teachers in the 1920s. And it started out as a risk pool for catastrophic expenses. So a bunch of individuals wanted to be able to provide group-funded support in the event of, you know, a excessive medical expense, rather than having coverage for routine preventative care. And this was how medical insurance was born. And even as early as 1932, a few years after insurance first began, there was actually a federal committee on the costs of medical care that wanted to include dentistry as part of a vision for funding comprehensive health services. However, due to opposition from organized medicine, modern medical insurance actually manifested itself as very differently from something that was publicly funded for comprehensive health services, and instead became a private, predominantly employer-sponsored system. And now getting into dental insurance. So dental insurance was ultimately not included in this medical insurance that arose in the 1920s, 1930s, and actually did not emerge until 1947. So insurance for dental expenses actually were created as a benefit for members of labor unions after World War II. So after World War II, these workers found themselves with a lot of bargaining power after passage of the Taft-Hartley labor law. And because companies were prohibited, so wage and price controls prohibited companies from increasing salaries to attract workers to work for them, employers had to think of other creative ways to attract workers. And they, one of the ways they did this was actually offering healthcare benefits as an additional tax-free compensation. And this is how dental insurance actually came into being. So dental insurance was one of the first types of compensation offered to these employees during this era. And then what was beneficial for the employer was that they could deduct the profits that they paid and the premiums to provide the benefits, and the members enjoyed it because they could, you know, enjoy comprehensive dental care for themselves and their families. Okay. But what was important was that this dental insurance actually worked in a very different way from medical insurance that was created a few decades prior. So although medical and dental insurance in the United States are both tied to employment, they actually have very, very different functions by design. So medical insurance operates off of risk pooling. It's designed to cover unpredictable expenses, sort of in the event of catastrophe, and that risk pooling serves to compensate for those types of events that are not as common. Whereas dental insurance is actually intended to fund predictable and lower cost preventative care. And the reason for this was that dentistry was actually regarded as uninsurable initially. It didn't have a definable risk, and when dental disease occurred, it often was not considered to be life-threatening. And also, dental problems were also present too frequently. You know, whether it was, you know, tooth decay or gum disease, there was too much disease for sort of dental insurance to function the same way that medical insurance did. And it was also posited that a lot of oral health was actually within the control of the individual. For instance, a lot of, you know, oral hygiene and things like that. So they didn't, sort of designers of early dental insurance didn't want to necessarily have to pay out large expenses if an individual, you know, was not taking care of themselves. It also presented with moral hazard in that it was regarded that if larger dental expenses were covered, more and more people would seek out, would submit for dental claims, and therefore make it more and more expensive and sort of impractical over time. And as a caveat, protection from catastrophic medical costs was perceived as a necessity, but coverage of dental services was the opposite. It was not perceived as a necessity. It was conceived as sort of an add-on, something that was just beneficial and nice to have, but not needed. And as far as the design of dental insurance, it also was similar to medical insurance in some ways, in that there are, you know, three parties involved. You had the individual, you had the provider, you have a third party with whom your employer would contract for coverage. Again, patients would be sharing the costs. It sort of would be through like paying for premiums. But some differences were that I mentioned this earlier, that there's dental insurance has a limited range of services. It tends to cover more preventative services such as cleanings, some basic fillings and exams, whereas more invasive procedures such as root canals, complicated surgical extractions, dentures were intentionally limited. Dental insurance did not want to have to pay out often for expensive procedures to control costs. Dental insurance also only offered coverage to groups, and there were often waiting periods after enrollment. And another unique feature of dental insurance was the use of pre-authorization and annual expenditure limits. So what that means is that when an individual had dental insurance and they wanted to use their dental benefits towards a treatment, they had to be pre-authorized by the dental insurance company to be able to be covered. So this would often involve sort of like a lengthy investigation process, and insurance companies would have to approve the treatment plans before treatment was even allowed to begin. And when cost of care exceeded some annual expenditure limit, the burden of payment was always put entirely on the subscriber of the plan. So basically, you would have to pay out of pocket entirely for anything over the annual expenditure limit, as well as for services that are not pre-authorized. And the reason why they did this was they wanted to avoid taking on too many high-risk beneficiaries. There are, you know, a patient can have systemic conditions that make them much more predisposed to having oral disease, and these types of these insurance companies, dental insurance companies, didn't want to take on too many of those types of patients to control costs. They want to avoid that self-selection of having too many of those high-risk beneficiaries. And as they grew, though, they did offer coverage to individuals at higher premiums. So dental reimbursement mechanisms. A lot of these are kind of familiar and similar to medical services. So some of them offered traditional indemnity, fee-for-service, managed care also is becoming more of a force, though it's definitely not common. PPO, HMO, capitation, just salaried reimbursement, and also public programs. And some slight nuances between all these is that in fee-for-service, there's just a fee for each procedure that is billed to the insurance carrier, and the insurance carrier reimburses the dentist for the services provided. And in this case, the dentist doesn't bear any risk. Whereas in managed care, there is some management of cost and quality, and the dentist often will have some sort of shared risk in reimbursement. In PPO, a network of dentists have agreed to take on fees for covered services, but the dentist is also, again, not at risk. And whereas in HMO, dentists are reimbursed on a per capita basis. So for each individual they're responsible for, they are paid for, irrespective of how many procedures they perform or how many services they provide. Sort of getting now into sort of how dentistry operates under public programs. So under Medicare, Medicare actually in the United States doesn't cover most dental care. The only instance where it would be covered is that in Medicare Part A, which is hospital insurance, if a dental service is necessary prior to performing a covered non-dental procedure, that is one particular instance where Medicare would pay for dental services. An example of this is that prior to an individual receiving radiation treatment on their jaw, Medicare in this case would cover a tooth extraction in preparation before the radiation. Otherwise, dental care services have to be paid for fully by the individual out of pocket, as they aren't covered under Medicare. So under Medicaid, they're actually it's a little bit more generous. In the United States, dental care actually has to be funded for low-income children. It's a component of the early periodic screening, diagnostic, and treatment benefit. And however, dental care for adults is considered an optional service, and it sort of varies state to state. Some states will cover a lot more dental services than others. I know that I'm most familiar with New York State because that's where I am currently training. In New York State, it actually has one of the most generous Medicaid policies concerning dental care. They will cover a lot of services for anterior teeth, which are considered more aesthetic, whereas molars are considered more, are not often as covered for procedures. Currently, 28 US states fund non-emergency dental treatment for low-income adults enrolled in Medicaid. And these are, I also include some graphics on sort of how many providers participate in Medicaid. So, and a particular striking statistic is that only about 37.5% of dentists participate in Medicaid compared to almost 70% of physicians. Whereas Medicaid fee-for-service reimbursement is actually, as a percentage, very similar for both professions. For US children, more dentists actually do participate in Medicaid. It's 39%. It's not much more, but there are more dentists that participate in Medicaid for treating children. Okay, the Affordable Care Act. So the ACA was actually did actually affect dentistry in some interesting ways. So under the Affordable Care Act, dental coverage is actually considered an essential health benefit for children. It's one of 10 essential health benefits. However, it is not considered an essential benefit for adults. And insurers don't have to offer adult dental coverage. Although that dental coverage for children has to be available for plans offered on the exchange. But what was an interesting ramification of this was that actually a higher proportion of adults obtained marketplace dental coverage through the plans offered through the Affordable Care Act anyway. So even though it was not by design for the Affordable Care Act to sort of be, it didn't place dental coverage as an essential health benefit for adults. Many adults actually got dental insurance through the plans offered in the marketplace exchange by the Affordable Care Act. And on the other hand, though dental coverage was considered an essential health benefit for children, many children, dental coverage actually did not expand to a huge degree as intended by design of the benefit. Trends in dental insurance. So these are just some sort of issues with dental insurance currently. So nearly half of Americans actually lack coverage for dental services compared to 15% who lack medical insurance. And 70% of individuals with insurance do see a dentist compared to 50% of those without dental insurance. And what is troubling about this is that, again, you know, there is a lack of dental coverage because it's not considered an essential health benefit under the Affordable Care Act. And what this is doing is that it's having some interesting ramifications. In some states that are facing financial difficulty, dental care is often cut out of funding. And what this results in is a lot of actually ED overuse for dental conditions. A lot of patients reporting to emergency departments for tooth pain, for toothaches, and roughly $1 billion is actually spent annually on palliating preventable dental pain in hospital EDs where patients actually aren't receiving any treatment at all because many hospitals are not equipped to, provide fillings or, procedure dental services that these patients would need to get themselves out of pain. And roughly $1 billion is spent basically, to, prescribe painkillers and things like that to patients that report to EDs with, pain. Another interesting fact is that Medicaid beneficiaries are actually still struggling to receive care as well, because, as I mentioned before, only about 30, I think it was 30-something% of dentists actually are enrolled as Medicaid providers. So reimbursement rates are often less than half of those paid by private insurers, and thus many dentists are discouraged from enrolling as Medicaid providers. Dental insurance coverage rates have increased dramatically for children, but have been declining slowly for adults. More children have been covered through the expansion of Medicaid and the Children's Health Insurance Program and the ACA covering dental care as an essential health benefit. But this increase in coverage has not been due to private dental insurance, which makes sense. More and more coverage has been provided through expansion of public programs. And especially increased numbers of low and middle income children have visited the dentist through these public programs. Also, major dental insurance carriers have significant market share concentration. And what I mean by this is that a lot of major private dental insurance carriers, a lot of the market share is actually consolidated in a few key players. So Delta Dental is a big one, Blue Cross Blue Shield. I think Aetna is also pretty big in some states. A lot of these carriers have a very large market share, and what that does potentially is that when market concentration could potentially results in either higher premiums for consumers or lower reimbursement for providers, because they have a lot of power in determining sort of fee scheduling and things like that. And what this is doing is one of the main impacts is that, again, expenditures for healthcare overall in the United States are very high compared to our peer nations. And this also is occurring in the dental industry. So total US dental expenditures is actually increasing. It was stagnant for several years, but within recent years it has been increasing. And dental care utilization is also at the highest rate ever among children, but it is actually continuing to decline among working age adults. So less and less adults are going to the dentist, more children are going to the dentists, and for older adults, it's about remaining stagnant. And there's actually a reason why a lot of working adults are actually not visiting the dentist. And the main reason is due to cost. It's reported that dental care has the highest level of cost barrier compared to other healthcare services. And a lot of these costs are also, it's costs associated with providing care, but it's also indirect costs too, as I mentioned before. There's a lot of ED overusage due to dental conditions. And generally, $2 billion is spent on hospital emergency departments for dental conditions in the United States. So what is a way of possibly curbing these uncontrolled costs? Possible solution is Medicare for all. So Medicare for all is definitely a potential remedy, because what it would do is that it would, just foundationally reinvent how dental insurance operates. Everyone would be in the same risk pool. There wouldn't be arbitrary expenditure limits. You would have, there'd be no need for pre-authorization. You would have sort of, essential, dentistry would be considered an essential primary care benefit. And it would allow for greater access. And you wouldn't see, again, some of these recurring issues that we're having in our country with oral health disparities amongst the poor, amongst the less educated, and etc. Providers would all be in network, allowing for freedom of choice for patients. And this is huge since that, again, a lot of publicly funded dentistry in the form of Medicaid, not many dentists are actually Medicaid participants and will not treat Medicaid patients. What is also beneficial is the government is able to directly promote health in this manner through a Medicare for all type of system. And as far as achieving the triple aim, sort of absorbing dentistry into a Medicare type for all system would help to reduce administrative overhead. It would allow for a better negotiation of fees. It would allow increased quality of plans. It would encourage rationing based on risk levels. It would also improve access. So future directions for dental insurance. So dental insurance definitely needs to be better designed to help an individual get care at reasonable costs. One of the main weaknesses of dental insurance as it exists today is that each person's oral health is different and costs can vary immensely. But by design, dental insurance is not designed to sort of treat those that have a lot of dental disease. A lot of dental insurance will only operate well for those seeking sort of preventative services, since there are there are expenditure limits, and it requires pre-authorization for services, and often only less expensive services are covered through dental insurance. To control costs, most plans will also limit the amount of care you can receive in a given year. So again, this is another big sort of weakness to dental insurance as it exists currently. And dental insurance also should be structured to pay for attainment of oral health rather than being checklists of procedures. So right now, dental insurance predominantly operates on reimbursing off of procedures in form of fee-for-service. What this is, it's difficult to control costs that way. And doing so, thus dental insurance should probably incorporate some sort of risk pooling similar to how medical insurance operates, where patients at high risk would be eligible for a different set of services than those at low risk. And that way, again, it would operate similar to medical insurance in that it would prepare for, those with dental catastrophes and sort of large expenses would still be able to benefit from dental insurance, and not just those who are in need of sort of smaller and preventative services. Another important directive is that dental insurance and the separation of dental and medical insurance should probably be reconsidered. And why is this? Is that because we know, again, that there are a lot of connections between oral and systemic health, and it is very, there is a lot of cost savings involved in treating sort of these chronic oral conditions in concert with systemic conditions, such as diabetes, cardiovascular disease, stroke, etc. And there actually have been studies by a few insurance companies that actually have found that there have been cost savings of more than $1,000 per capita when preventative dental treatment is provided to high-risk groups, such as people with chronic conditions, diabetes, and cardiovascular disease. So this, again, points to the direction that medical and dental insurance, though historically they have been divorced from one another, this should probably be reconsidered. And a way that this could be reconsidered is through a Medicare for all type of system. And this also follows major trends in the U.S. healthcare system overall, in that it is moving away from fee-for-service towards individual procedures, treating just an individual patient, and more towards having population-based care, promoting wellness, preventative services, and incorporating value-based reimbursement into financing of healthcare. And this was actually a tweet from the U.S. Surgeon General in January 2019. So the current U.S. Surgeon General happens to be a huge advocate of oral health. And what he did tweet here is actually he believes that oral health should not be an add-on as it is in our current system, where dental insurance is not something that's compulsory. It's sort of an added benefit. And rather that oral health adds a lot of value and should be incorporated into overall healthcare coverage. So, and exactly how would this look specifically? So there are a few examples of how Medicare for All could be executed in having dental coverage. So currently the American Dental Association does not actually endorse the inclusion of a dental benefit under Medicare at this time. So the American Dental Association traditionally, similar to the AMA, has not does not really favor having outside regulation in having jurisdiction over what is covered and what isn't. So the American Dental Association is against having a dental benefit under a Medicare type system. Under Bernie Sanders' proposed single payer system, dental benefits are covered in addition to hospital visits, primary care, drugs, vision, and medical services as well. In the New York Health Act, dental is also covered in concert with comprehensive medical care and vision, and it would be funded through a centralized New York Health Trust Fund. And as far as in other countries that operate Medicare for all type systems, so in the Canadian healthcare system, they actually do not cover dental care and vision, and the majority of Canadians take out private insurance policies to cover their dental care. In the Netherlands and Australia, they similarly exclude dental and vision services. In the UK, the National Health Service does treat does provide some basic dental coverage, but many people will also seek sort of private dental coverage for if they have more extensive needs. And as far as incorporating oral health into a Medicare type system, I think what's important to understand is that sort of how you can promote advocacy for oral health. So one of the ways you can do this, you can seek out becoming educated on oral health. So there is a national curriculum specifically designed for primary care providers, including physicians and nurses, to promote oral health for a variety of populations. Another way you can connect with your university's dental school and dental students, introduce them to SNAP. Supporting oral health integration with primary care is another key avenue. And lastly, also spreading the word to your colleagues. And that is it. That is all I have for my presentation. And if anyone has any questions, feel free to type in the chat box or whatever.
You can also use the microphone if you have a question. Okay. Well, with that, unless I get a question that pops up in the chat box, thank you so much, Ben, for such an awesome presentation. I feel like I really learned a lot, and this is going to be very useful in the future. If anyone is watching and you're interested in learning more, oh, Richard has a question. Go ahead. I'll type that in. We'll wait before I go on. Wait just a second, and I'll read the question once it comes through. I guess while we're waiting for Richard's question is, if anyone watching is interested in learning more about PNHP or SNAP, you can visit student.pnhp.org or search for Students for a National Health Program just in a Google search. There you'll find an opportunity to join PNHP, which is free for all students. You'll receive emails and regular updates from SNAP. You'll also find a list of current chapters to see if your school has a SNAP chapter established. You'll find resources on ways you can learn more about single-payer healthcare and Medicare for all, including access to our previous webinars and a single-payer one-on-one talk under chapter resources and webinar series. So Richard's question is, he said, a lot of my classmates are concerned with costs. Are you talking about just Medicare for all in general, or is it specifically adding dental? It says right now dentists have to abide by the fees that insurance companies set and are obviously upset with that. Ben, do you have any thoughts on that?
Yeah, I do. I think that.
Oh, sorry. He said, as it stands, how will fees be determined under Medicare for all?
Yeah, so I think that something that I mentioned in my presentation was that right now there are a few key dominant players in the dental insurance industry. I mentioned like Delta Dental, a Blue Cross Blue Shield, that sort of have a majority market share, and that they have almost 40% of the market. That was the graphic I had about California. And what that does is that gives them a lot of bargaining power to be able to set their own fees. And these insurance companies don't always have, the provider or patient, the patient in mind of, having the best interests of the patient or provider in mind. And thus, I believe that having a Medicare for all type system where you would have sort of, everything would be centralized, and you would be able to have much more egalitarian, a more egalitarian fee structure, because everything would be centralized, and you wouldn't have sort of key players dominating the environment on what fees are considered reasonable or customary.
Awesome. Does anyone else have any more questions or any follow-up questions to that? Richard said thanks. All right. Well, if there aren't any more questions, just want to let everyone know our next webinar is going to be focusing on the nursing field, and that will be held on Thursday, March 21st, 2019 at 6 p.m. Central Standard Time. We'll be promoting it more throughout the next couple weeks. And don't forget, our annual SNAP Summit is this weekend, Saturday, March 2nd at 9 a.m. at Columbia University in New York City. Online registration for the event has closed, but on-site registration will be available day of at the summit. More information can also be found on our website, which again is student.pnhp.org. Thank you everyone for tuning in, and have a great evening.